There we go. All right. So, Dr. Bekkering, I will restart. As a pediatric physiotherapist and postdoc researcher at the Princess Maxima Center for Pediatric Oncology in the Netherlands. In 2011, he received his PhD for a study on the quality of life, physical functioning, and physical activities of children after malignant bone tumor surgery and around the knee. As a postdoc, he is involved in various studies in orthopedic oncology, including shared decision-making, follow-up, sports participation after bone tumor surgery, and physical activities. Currently started with projects for rehabilitation and the streamlining of postoperative care. And with that, I should probably say too, my name is Ann Gonzalez. I am the education co-lead with Lynn Tanner for the PSYOP Rehab and Physical Medicine SIG. So we welcome you to this presentation. And Peter, I'll turn it over to you.
Thank you very much. I hope I have a pleasant presentation for you. Scan data. Yes. Okay. Okay, I hope it works.
Peter, I don't think we can hear it. Can anyone else hear it?
Oh.
Maybe, did you check the box when you share it? There's a box that says like share your audio or something like that.
Okay.
Might be that?
We look. I look. Yes, it's okay. Where do you find it?
So, Peter, on the if you go to the icon that says share, somewhere on the right-hand side there should be a few boxes, and one says share audio or share sound.
Okay, let's try share, and also share audio. Thank you very much. A new start. Welcome at this webinar from our PSYOP Special Interest Group. I'm pleased and honored to be the first presenter of our group and hope many of us will follow. My name is Peter Bekkering, pediatric physical therapist and postdoc researcher at the Princess Maxima Center for Pediatric Oncology in Utrecht, the Netherlands. My presentation will be on shared decision making in children undergoing malignant bone cancer surgery of the leg. This is Professor Tominio, a surgeon for orthopedic oncology, which one I've been working for several years in the care for children with bone cancer. Malignant bone tumors, like the osteosarcoma and the Ewing sarcoma, are rare and count for approximately 6% of cases in pediatric cancer, with an incidence in the Netherlands of approximately 35 new cases a year. Unless remarkable improvements in survival of pediatric cancer, the 5-year survival of bone cancer stays behind with only 60%. Malignant bone tumors have the highest incidence during puberty, between the age of 13 to 15 years old. In children, 70% of the cases of bone cancer are located in the lower extremity and especially the knee region. The treatment of bone tumors consists of chemotherapy before and after the necessary surgery, according to international protocols. In Europe, we use the EUROMOS and the Euro-Ewing protocol. In the case of a tumor localization in the knee region, there are usually 2 or 3 surgical options, divided into bone sparing procedures with after removal of the tumor and reconstruction of the extremity, and ablative procedures like the amputation or rotation-plasty without any reconstruction. With the reconstruction of the knee with an endoprosthesis, you have the great advantage of preserving the leg. But the reconstruction with a metal-hinged knee joint is vulnerable to infection, loosening, and intensive weight-bearing activities such as running and sport is not recommended. In addition, a maintenance operation may be necessary within 5 to 10 years due to wear of the prosthesis. A reconstruction with bone from a donor or the patient's own fibula can only be performed if the knee is not involved and also has the advantage of preserving the leg. However, the disadvantage is a long rehabilitation of 1 to 2 years before the bone is fully rebuilt and intensive weight-bearing activities are possible. In addition, there's a risk of non-union or fracturing of the donor bone. Ultimately, however, intensive sport and weight-bearing activities can be resumed. An amputation was initially mainly performed if reconstruction of the leg is not possible due to extensive involvement of nerves and muscles, or when the chemotherapy response is poor. Despite the cosmetic disadvantage and the dependency of an external prosthesis, this is also done when the patient wants to participate in intensive sports and does not want to run the risk of complications and reoperations. A rotation-plasty is a choice that's often made in young patients because of the possibility of anticipating on leg growth, the possibility of being able to do intensive sports, and the limited risk of reoperations and complications. The disadvantage of this procedure is clear: the cosmetic aspect and the dependency of an external prosthesis. My task as a pediatric physical therapist consisted in the past of explaining the consequences to patient and parents shortly before their surgery in a simple language, providing guidance after the surgery and assisting the surgeons during the follow-up period. Over the years, I therefore developed a great deal of knowledge and experience with the final outcome of the different surgical interventions and the advantages and the disadvantages of the individual procedures. In addition, I saw many children with an amputation and rotation-plasty during pediatric oncology ski holiday camps, where I noticed how many possibilities this group had during sport and exercise and how they stood firmly in life. We therefore often had discussions with the surgeon about what would be the best surgical option for an individual child. Why not opt more often for a rotation-plasty or amputation for a young child or child who really enjoys sport and exercise? The professor therefore suggested that I should start investigations on the quality of life and functional possibilities in daily functioning, to to tell him at the long last which surgical procedure would have the most advantages for this patient with the tumor around the knee. However, our and several other studies into functional possibilities show that there are only small differences, alternating the advantages and disadvantages for one of the ablative or limb salvage procedures. Also, in the field of quality of life, there were no clear differences between the surgical options. However, we saw small differences in the quality of life demonstrable when you looked at the young boy who appeared to have a clear preference for the ablative procedures, or an older girl who appeared to be more satisfied with the limb salvage procedure. This is why I sat down with Professor Bramer from the AMC Amsterdam to set up a plan on how we could improve the outcome of our patients. One possibility seemed us to include the personal preferences of the patient in addition to the surgical and oncological considerations when making a decision for the final surgery. For determining the personal preferences, it's important to know, for instance, is the patient more interested in the appearance, or does he or she want to be able to participate in sports and would like to move more freely without the risk of complications after the procedure. One method which makes it able to include personal preferences in medical decision making is the process of shared decision making. Since a large international meeting in Salzburg, it has been an important goal of healthcare providers to involve patients in making choices in the medical treatment. Furthermore, they also have the legal right to do so. Shared decision making is especially important when choices have to be made in healthcare decisions between somewhat equivalent options, with multiple outcomes and with different advantages and disadvantages to these options. It is important in shared decision making to explain to the patient that there are choices, what the consequences of the choices are, and that they are actively invited to participate in this decision. For our study, we started with a systematic review that showed 70% of orthopedic surgeons support shared decision making, and that 80% of their patients want to be actively involved to this choice. However, shared decision making in pediatric oncology is rare and is currently only seen in children with a brain tumor when deciding whether or not to add radiotherapy with all the intellectual consequences, palliative choices, and prior to the risky treatment of a bone marrow transplantation. Our next step was to evaluate the current situation by means of stakeholder analysis. This analysis consisted of questionnaires focused on the degree of shared decision making, experience and preferred involvement, conflict feelings, and disappointment about the result of the surgery. In addition, open questions were added, which were presented to the child, parents, and the other caregivers. Surgeons and other caregivers indicated that there was an insufficient material available. Patients and parents indicated that they would like to hear more about the surgical options, more technical information, and visually see the results. Despite a considerable degree of experienced involvement in the choice, children and parents indicated that they wanted to decide more together in cooperation with their surgeon. A considerable number of around 50% experienced a serious degree of conflict between them and the surgeon during the surgical choice. More than a quarter of the patients and parents indicated that they also had average to strong feelings of regret about the result of the surgical intervention. And when we look at the relationship between the different measures, we see that the greater degree of involvement, as measured with the shared decision-making questionnaire, in the surgical decision gives significantly less conflict between the surgeon, the patient, and the parent. Furthermore, we saw that less conflict feelings in turn gives significantly less feeling of regret with the functional result. In order to implement shared decision-making in the surgical decision of patients with malignant bone tumors, we were faced with the challenge of being able to inform patients and parents extensively understandable about the surgical options and what the consequences and differences are between them. This is why we have chosen to set up a digital decision aid. With this decision aid, patient and parents can choose in their own environment which option they want to see explained. They can repeat it and they can see it with all the people they want besides them. Yes. Can you hear me? I think I have to take over because the presentation didn't record further. So I shared the screen again, and now I'm doing it by my own. In the decision aid, they receive technical information about the procedure, when, why, and how it's performed. In the decision aid, they receive technical information about the procedure, when, why, and how it's performed, the advantages and disadvantages of the different procedures, and what the functional and supporting abilities are in the short and the long time. Furthermore, there are pleasant, informative animations for each procedure. For each option, we used honest and clear photo material. Hereby, we did not choose the remarkable, well-functioning and good-looking patients, but comparable examples like themselves. The decision aid contains a lot of information that the patient found for importance during the survey. Complications, daily functioning, social participation, work, appearance, and the sportive ability. For the application of shared decision-making in the practice, one of the founders of the shared decision-making process, Glenn Elwin, has created a schedule in which the moments and content of the various conversation moments are shown. For our patient group, we have translated this into the schedule of chemotherapy. During the first conversation, for example, it is explained that a surgical intervention must take place, and we ask to what extent the child and the parents want to be involved in the choice. During the second conversation, the surgeon explains the available surgical options and gives the decision aid. During the third conversation, a physical therapist and rehabilitation physician further clarify the information. Look to the information from the decision aid, and patients were invited to express preferences and wishes. This is followed by the final conversation with the surgeon, in which the final choice is made in consultation between patient, parent, and the surgeon. The conversations during shared decision-making should have the right tone and attitude. It should be stated to what extent the patient and parents wants to be involved. It should be an open conversation with, in addition to clear explanation, also good listening by the surgeon. The professional gives his opinion without directing the patient too much. However, it's about an equal partnership. The information should be given honestly, without leaving things out, with all the pros and cons that are listed. The surgeon should look for the preferences and doubts of the patient and regularly summarize what he hears. And finally, they should come to a shared decision upon the surgery. In summary, for implementing shared decision-making for a medical decision, you need clear information for the patients. Communication, all aspects concerning the decision. A time pad with enough time to make all the different steps, and the right attitude in the healthcare providers to share the decision actually with our patients. We have been using shared decision making now for 2 years in making the surgical choice in children with a malignant bone tumor of the leg. In order to share our experience, I have a few examples for practice to share with you. The first 2 cases concern 2 boys, aged 15 and 16 years old, and were diagnosed almost simultaneously with an osteosarcoma of the proximal tibia. Both were told during the first admission about the necessary surgical intervention and that they and their parents could participate in this decision. They all received the digital decision aid, and we all made the same steps as mentioned earlier. The option they were offered at the second consultation were a limb salvage procedure with an endoprosthesis, or an endoprosthesis with allograft, or an ablative procedure with an amputation or rotationplasty. The digital decision aid was handed over, and a consultation with a physical therapist and rehabilitation physician was scheduled. The first boy was a long and tall 15 years old student at the secondary school. He did modern dance, a sport, and hoped to be able to start at theater and dance education after his examinations. His wish was that the surgery would not be an obstacle for this, and that he has seen, and after he has seen a video of Gaby Shaw, an American girl who dances at a high level after rotationplasty, his choice was clear. Despite the fact that the surgeon considered him an ideal candidate for a limb salvage procedure with an endoprosthesis, a rotationplasty was performed after 4 months. With great dedication, training to master walking and athletic movement with the prosthesis, he can now participate in dance training again. The rotationplasty was well accepted by him and his parents, and he even participated in the television recordings in the Netherlands when he talked extensively about the procedure and showed his leg to the audience. The other boy was 16 years old, went also to the secondary school and lived and worked on his father's farm. With little interest in sport, his great wish was to be able to drive the tractor again as soon as possible after the procedure and to take over his father's farm in the future. His choice was therefore an endoprosthesis with a graft composite. He has trained with great dedication on the mobility and function of his new knee, and he walked a lot and was soon able to function without crutches and to walk without asymmetry. He is currently driving his tractor again, and he can even run a bit. Sometimes he joins one of the golf clinics of one of our former patients, and he's very happy with the result of the surgery. We also apply the shared decision-making to patients with a different cultural background. The third case concerns a 6-year-old boy, a refugee from Syria with a deeply religious parents and who have great difficulty with the Dutch language. He was diagnosed with a Ewing sarcoma of the left median femur. In his case, it was quite possible to perform a reconstruction using an allograft and vascular fibula after resection of the tumor. Given the communication problems and the expected preference of this Islamic family and an intact the preference for an intact body, the options of amputation and rotationplasty were not mentioned. This is what the reconstruction ultimately looked like, with an addition to the allograft and 2 pieces of fibula, several plates and screws. This was a very limiting surgery, and he was isolated in a wheelchair for 6 weeks. Unfortunately, upon inspection of the pathologist, the surgical margins were not clear, and small micrometastases appeared to exist outside the surgical area. In this new situation, a choice had to be made between extending the treatment with other chemotherapy, radiotherapy, which could mean that the donor bone may not survive and much more surgical interventions are necessary. On the other hand, it was possible to perform an amputation or rotationplasty, which will probably give a better chance of recovery. This time, the shared decision-making conversations were conducted with the help of an interpreter. With extensive photo material, a Syrian fellow with a patient with a rotationplasty, and with plenty of room for the parents to explain in their own language and our own way to the boy. Despite the language problems, the conversation went remarkably smoothly, and the child and parents jointly decided to perform an oncological, more safe rotationplasty. Despite the necessary high-dose treatment and the stem cell reinfusion, he adapted very quickly to the new situation and participated skillfully with 2 elbow crutches doing sport and games activities in our hospital. The rotationplasty is remarkably well accepted by the boy and his family. Question remains, is shared decision making the solution to our problems? It's important to notice that it's not easy, and the choice remains difficult because the parents have to make a decision for the child and they feel the pressure. That's always important to keep in mind. Are patient and parents able to choose? important step is the knowledge. We have the knowledge about the surgery, the outcome, and the consequences. We have to explain it to the parents, otherwise they're not able to participate in the decision. Some surgeons said in Advantage, shared decision would be too time-consuming. We experienced that the time is not more than in before. The most positive part is that you know which conversation will be held at what time and which material you can use. Therefore, it's less time-consuming. Another question was, there's a risk for wrong choices. In the 2 years we used the shared decision making, we did not see the patient to make wrong choices. A wrong choice is when it's oncological, not safe, but the surgeon is a partner in the talking, in the decision, and therefore he can tell them what the pros and the cons are, the different options. It's different. In the past, we saw more patients with limb salvage procedures, and nowadays the rotationplasty is the most seen surgical intervention in this group. Is shared decision making also an option with other tumor localizations or with surgical options that are less equal in pros and cons? We think so, and we saw that our surgeons used shared decision making more and more because if there are a big difference between the surgical options, they can tell what these differences are, and patients seldomly or never choose for the more riskful surgery. For instance, some of the other localizations did very well with shared decision making. For instance, with the tumor localization in the upper femur and the pelvis region, and then we have to choose between internal hemopelvectomy or and lumic prosthesis. And that went very well. Our PhD is quite far now in her PhD track, and we have 2 beautiful publications that you can read. And I thank you for your attention.
Thank you, Peter, for that incredible presentation. Now we'll open it up to the group for questions and discussion.
No questions, that would be the straight. I was so clear.
Hi, Peter. I'm Anna. I'm going to do a disclaimer before I start to speak, because the last time I speak in English was in our reunion in Italy, so it's like a little bit rusty. It was really, really clear. We had in Argentina, in our hospital, 31 patients per year with bone tumors, osteosarcoma, and Ewing sarcoma. And I like to know if you are part of the reunion with the parents and the surgeons to explain the possibilities and the, I don't know how.
I understand what you mean.
Okay.
We have made clear choices. The partner in the decision is the surgeon, and only the surgeon. He talks with the parents and the child, always with child and parents together. Even if the child is 4 or 5 years old, the child is with the parents, and sometimes it's necessary to have a short conversation later, but the family is one part of the decision, and the surgeon the other. We think it's very important to have somebody neutral with these talks, and that is in our case the nurse specialist, or you can look for a pediatric worker, but they are not talking, they're only listening. Me as physical therapist, I give with the rehabilitation doctor, we have an open talk without talking about the choice, because we are not part of the decision. That's the parents and the surgeon. So we give only information and we help them to find additional material. For instance, like the boy from Syria, it's important that he can see another boy who talks his language, and that works very well. And in the past, the oncologist and the psychologist, it's much more people were involved in the decision. And to make it easy for the patient and the parent, we located in the surgeon and the parents. So it's no group conversation, only they are the partners in the decision. That works very well. We're happy with our surgeon, but even one of our surgeons was older, less experienced in this way of working. He did well with this rules.
Okay, we have the same arrangement. They have the first talk for in a separate time, and then we have a second talk when we want to talk about just the rehabilitation program and the follow-up of the patient. And we mainly give the message that maybe they are going to stop visiting the doctors that much, and they are going to come to the hospital just to physiotherapist.
Yeah.
Okay, thank you.
And the interesting thing, that's the reason I've used the boy from Syria. In the past, we always thought that we knew a lot about culture, persons. If it's a girl, our surgeons say, oh, it's better to save her leg because she wants to, appearance is more important. When we have Muslims, and now we have, most of my patients at the moment are from the Ukraine, but also with other cultures, it's important to inform the patient and give them the right to talk. If they are more from a culture that the doctor have to decide, okay, that's part of the decision, because there is space, and you ask them to what extent you want them to discuss. We also had a boy, and his father said, "Doctor, you are paid well for this, you have studied for it, you decide." Okay, that's his right, but that seldomly. We mostly see different. For instance, the boy we used for the fellow information was a boy from Syria, from 9 years old, and we had his talk also not with shared decision making, but because we thought they didn't understand our language. They're just refugees, come from a terrible situation in Syria, and we were talking about the endoprosthesis, and the boy himself said, "Dad, I saw on the internet that there is possible to have a rotation plasty, and I can't sit that. I'm hyperactive. I want to sport. I want to be active. That's not possible." So he himself gave us the reason. Therefore, we give all the patients all the information, unless culture. Any more questions? Wonderful.
It looks like we may have a few.
Let's
see.
You had them in the chat.
Ratna, do you want to go ahead?
Yes, I have a question. I'm Ratna from Indonesia.
Hello, Ratna.
Hi. Hi, Peter. Thank you for the talk. It's very informative and useful. And I have two questions. The first question is, how much time is it do you need from the start of the diagnosis till the patient comes up with the decision? And my second question is, how much time in average do you need from time of start of rehabilitation till the end of that they reach the expected goal? And when do you start the rehab after surgery? Thank you.
Okay. In the past, the talk about the surgery was mostly after the last MRI, and that is that after the last during the last chemotherapy. So there was 2-3 weeks before surgery. That was not possible to talk about different options because the parents have not the time and the energy to get information, to talk to other people, so therefore we use a very strict during the first consultation during chemotherapy. It's the first chemotherapy, so we have nearly 3 months between telling them that there should be a surgical intervention in the traject and we give them all the options that are in that case possible, and the last MRI when the decision is finalized, because if the tumor is not responding well, some option will fall off. But mostly we have 3 months with all the talks, and sometimes it's necessary to have another talk, and sometimes the decision is earlier made, and then we have as physical therapists and rehabilitation doctors in the last chemotherapy another talk about to telling them how the rehabilitation will take place. But the timeline is very important because you can't have the patient and the parents make a decision when you don't give them time. They need time to get the information. They have time to talk. Yesterday, one of the surgeons had a talk with a girl and his mother, and she was crying a lot. So the next talk with me will not be the same day, but a week later. It's tailor-made for the patient. After the surgery, in Utrecht, we are working on rehabilitation protocols, because many studies all over the world on our patients about the outcome are not possible to compare them, because in some hospitals patients with after surgery stay in a wheelchair for 3 months, sometimes more. But in Utrecht we start at day 1 after surgery with rehabilitation, and mostly at day 3 we start with physical activities, the transfers from bed, chair, walking, and all children are within a week can walk with crutches and can start physical therapy, and we all send them to a pediatric physical therapist in their neighborhoods. So we have a very fast recovery, and I know in other countries they have much more time, but we have the opportunity that our surgeons are 5 days a week in the hospital, so we can always look with them if how's the scar, is there an infection, what can we do, but all what's possible as fast as possible.
Okay, thank you very much.
Thank you.
Thank you, Elna.
Philip, I think you're next.
Hi, I don't know if the others who were raised their hands would like to discuss the Peter's answer for the Ratsana's question or not, because I've got different questions too. So I will go ahead. Okay. Thank you, Peter. Thank you, Peter. Thank you also for those nice case studies, which we really say how it works in practice. I've got two questions. One is concerning about the amputation rotation plasty, because this is some kind of operation we do not see in the Czech Republic. Sorry, I'm from the Czech Republic. Do you have any neurological complications of this surgery, and how many? And the second question is just about this shared decision making, which I really love this consequence to make the parents and the children also like involved in this decision, which is really nice psychological principle. I'm just thinking about the general principle of shared decision making, because your presentation it's a really big decision, and you said that it's the surgeons and the parent decision, and the rehabilitation just takes a part with this nice consultation and so on. But I think we are very full of these shared decision making in just rehabilitation. Would you like to go to the rehabilitation clinic, or would you like to rehabilitate at your home? Would you like to make the rehabilitation like really strong, and it will be one not so pleasant, or would you like to have this rehabilitation like let's say soft and funny, and so on and so on? And I think from my point of view, or from my experience, we do not have so many outcomes to say. If you will go to rehabilitation clinic, we have got these data that your whatever rehabilitation will be better, or if you will go at home. So these are only our experiences. What are your recommendations for this, trying to do this shared decision making also in the cases that we do not have those great outcomes, the data as you have in this different parts of surgery? Thank you.
Yes, a lot of questions, Philip. Luckily, we have next week to talk a lot about all the things I didn't tell you. First, in the decision aid, it's important to include scientific data. You asked, for instance, about rotation plasty. In my experience, I've seen more than, I think, over 100 children with rotation plasty. We have seen one boy with a lot of complications that went not functioning with the ankle and did the sign amputation. So he has a very long stump and his foot under it. So he did have at the end a normal amputation. And we have one girl with some nerve problems with a not good functioning knee extension, but she didn't have extra surgery afterwards. So complications from the rotation plasty are very rare, but we also tell them, for instance, how many patients have after an amputation phantom pain, and how many patients have to have, for instance, after the endoprosthesis, you can have in 30% of the cases in 5 years an infection, and there are approximately 2% that have to have an amputation afterwards. So all these information is technical information is packed in a very patient-friendly way at the decision aid. The other thing about rehabilitation, during chemotherapy, me and the rehabilitation doctor of our hospital are responsible for the rehabilitation. So we don't send the patient to the rehab center. Only when they have a prosthesis, we send them to we have a strong connection with one rehab center very nearby our hospital. So all the patients with a rotation plasty and amputation get the first prosthesis in that rehab center, but we are involved, we are controlling the rehab. When they're finished, we mostly we get help from pediatric physical therapist or adult physical therapist in the neighborhood of the patient, because they have very little time. If you send the patient during chemotherapy or a rehab center, you say, okay, next 2 weeks you will be at home, then you can go to the rehab center. And mostly they has fever and aplasia. So the chemotherapy is displayed for 2 weeks later, and then it's difficult to communicate with the rehab center. Physical therapist in the neighborhood is much easier in that way. After the chemotherapy, we look what's necessary, and sometimes it's necessary to have a longer rehabilitation, but we see very little children that have to go to a rehab center after 3-4 months after the surgery, because most of the problems are easy to do, to manage with a physical therapist in the neighborhood. Yes.
Hi, Peter. Can you hear me?
Yes. Hey, Marco.
Hi. Hi, I'm Marco from Milan. Thank you for your great presentation. I just have a question. You told us that you saw in the literature that there is no difference in the quality of life between the amputation and the internal prosthesis.
Yes.
I would like to hear your comment about this. Do you really think that it's important, and this is true in your experience? And because you know, this could be that everyone has his own path and his own decision making. It's important, as you told in your presentation. What do you think about it? What's your experience? And also about, you told us about the regrets, patient that regrets that they did maybe the wrong choices about the prosthesis. What's your experience with this case? Because it's something that also here in Italian, in Italy, it's something that is quite important to discuss also with the patient. And it's a really big task and really big decision. So it's a pity to discover later that you made the wrong choice.
Yes, yes. That's true. If you look at quality of life and functional abilities in the research, it's not that strange that they are comparable, because they mostly look at daily functioning. Can you walk? Can you do stairs? That kind of things. There is not a difference between the surgical interventions. And but if you look at, for instance, sports, we did now research on sportive ability after. We see much bigger differences, especially in advantage for amputation and rotation-plasty patients. They're doing much more intensive sports, skiing, football, basketball, while most of the endoprosthesis patients stayed with fitness, for instance, fitness and physical therapy. The important thing is to look in what's important for the patient, because if you are happy with doing fitness and you can walk, you can run, okay, then you make other choices than that you are very willing to have an active life. I want to do sports. I want to go out with my friends, dancing, skiing, and my cosmetic result is less interesting. That's the reason why we started this project. And to be honest, I think that if I look at regret, I knew it from the past. I had several times patients with a limb salvage, but also with a rotation plasty, and they say years later to me, Peter, why didn't they tell me there were other options? Because probably I would have chosen differently. I think that by informing the patient well and give him the possibility to decide jointly with our surgeons and our parents, that the regret feelings will be much more less, because you knew in advantage. So you much more, if for instance, if you have especially the allograft and autograft reconstructions, they're beautiful. In 2 years, they have if everything goes well, that's important. If it goes well, you have a leg, then you can do sports, you can do skiing, you can be active, but it costs 2 years of your life. If you know clearly in front of the decision that would be the consequence, you have an other start than that you thought, okay, my leg is finished, the surgery is done, chemotherapy is ready, when can I start doing football again? So it's very important to be clear to the patient what they can expect. And we know, especially we as physical therapists, we know so much about our patients. We can inform them so good about what they can expect. Is that enough for your question?
Yeah, it's clear. I don't know if there is also a lack of literature about this case, because it's a rare pathology. So I don't know if I was wondering if the literature that you told it's fair for you, or just, I don't know, the lack of experience is the problem that everyone has to can choose between rotation plastic or amputation about their lifestyle and their willing of do sports, as you told. But
yes, and there are also intercultural differences. For instance, in some cultures, I knew in Italy, from Bologna, in the past they did rotationplasty, and later on they say, okay, it's cosmetically not done, we stop with it. And for instance, in England they never did do a rotationplasty, and I was there in London for their first patient 5 years ago, I think. And now you see them doing more rotationplasties, because not knowing it, and the no experience with the surgeon makes the difference also.
Yes, and also thank you for also the regret, because it's a big burden that we used to carry in our life.
Yes.
In 10 years, I saw a lot of patients that told me, as you told before, maybe the amputation could be better for me because I could run, it's not so easy. It's something that sometimes we underestimate, I think, also in Italy.
Yes, I think so, yes. Therefore, we are working on translating our decision aid, not because it's not possible to make our own decision aid in other country, but it's so important to get the scientific evidence inside of the. So if we can make one version and we can translate it in several languages, it's easier to start shared decision making in other countries.
Looks like we have 2 more questions. Abu, you want to go next?
Thank you. I'll go very quickly. I'm just aware Jennifer's got her hand up and I'd really like her to get her question. So Peter, thank you first of all. And I'm just going to raise something that maybe we can carry on outside of the meeting. And I was just really grateful for you bringing up the cultural elements in your presentation and the case study that you gave. And one of the biggest bits of feedback I have had in this circumstance as a physiotherapist is family members from cultural backgrounds saying there are no resources that represent our children. So it's very difficult for them looking at images. And you brought up that video, and I'm sure many of us have used that wonderful young lady, Gabby, who's the ballet dancer. And it's a brilliant resource, but many of our families from different backgrounds, they and their children, it's difficult for them to relate to that. So I wonder whether, and I'm going to put the email of the SIG in the chat, whether there's a group of people who maybe would think about if we could share with consent some images that we can use, so we could have a database of culturally sensitive and appropriate images to be able to use with children from different backgrounds, particularly, I'm sure it's, you've mentioned the current area that you work, and I work in London is a very diverse area, and it's very common for us to be working with families from different backgrounds, and we struggle. I look on the internet and I find pictures of war veterans or Paralympians that I use, but it's not very appropriate for children, but it's all that we have. So if we could put something together, I think it may be helpful. But like I said, just because of the time, I'll put the email in the chat, and maybe that's something we as a group could maybe look to put together. But yeah, I just wanted to mention that. I'm very happy if you've got anything to say, but yeah, I want Jennifer to be able to answer her question. So thank you again.
I think you mentioned a very good thing. And we are in Utrecht very busy with combining pictures from different sides, different ages. I've even had, we had an Arabic girl with a high amputation that she was very afraid for it. But then I found from Iran a girl with crutches and very happy in life. So that's important to if you find that kind of things on the internet, we can combine it. That's very, very good. We'll talk about it later.
All right, thank you very much. I'm trying to make it quick as well. I'm Jennifer from Munich. And thank you, Peter, for the talk. My question is not really related to shared decision making, but since you were talking a bit about rehab programs and aftercare, I was wondering, do the patients also receive prehabilitative physical therapy? Because, of course, there are oncologic patients, but due to the surgery, there are also orthopedic patients, and we do know that orthopedic patients do benefit from training before surgery. So do they get a prehabilitative training, and is it somehow specific to surgery? Yeah, they're getting.
Yes, definitely. In Utrecht, we are very busy with physical activities during chemotherapy. Our group are mostly somewhat older and limited due to that. When you have a toddler that likes to run and play, that unless they have chemotherapy, but these patients are much more gaming, sitting. So we invite them to go also for sport. But now we started a project for Fit for Surgery, because all our patients, 70% of our patients, probably more, have to have surgery after 4 months, and then they have to walk with crutches. And how the rehabilitation is the most fluent if you can walk with crutches, do the stairs, be active, have enough strength in your arms, your belly. So we are working on a bigger project, but we already started it in our patients for Fit for Surgery, because if you let them less go down in strength and physical activity, the rehabilitation could start earlier. And if you, up a higher level, start your post-operative rehabilitation, you probably will have less problems with joint motion, muscle strength, limited functioning. So we're definitely working on it. Yes, and we hope to present next time more about it. It's not at the moment. It's mostly usual care. It's more an evaluation. We don't use it as research at the moment, because it's more important for the patient that it is possible. And we structurize physical therapy after the first chemotherapy, and during each chemotherapy training at the hospital. So yeah,
okay,
definitely.
Thank you very much. Just a quick question for that. Do you focus on something specific then? Because you were talking about core strength and yeah, how to train them or get them the best possible situation before surgery. Do you focus on something specific, or is it an all over training.
No, especially strength, arm, torso, and the other leg, because if you have an amputation or a limb salvage, you always have to depend very much on your other leg. So you can do squats on it, or jumps, or there's much more possible to deal with these patients than we thought.
Okay, thank you very much.
You're welcome.
I was gonna wrap up, but Gemma, I see you have, if you've got a quick question, maybe you get the opportunity to ask Peter real quick.
Yeah, now, sorry. Thanks, Peter, and hello to everyone from Barcelona. Peter, my question is, could you explain a little bit more, or maybe in another presentation, because it could be quite longer, about the advantages and disadvantages of each surgery?
Yes, that costs much more.
I know.
Yes, we did some research on it. Yes, and in the articles we presented, but I summarized it a little bit because it's but maybe we have to have longer time to talk about all the different the special pros and the cons, because each surgery has also several how do you call it, other variables. For instance, if you have an endoprosthesis, it makes a big difference if it's the endoprosthesis from the distal femur or the proximal tibia, and if you use a graft, for instance, and that makes yeah. So that's too difficult to explain it in a short time notice. Yes.
I know.
We're working on a rehabilitation protocol, and there in that rehabilitation protocol, we will ask colleagues from abroad also to give their information, what they think about it, because we want to limit the complication by putting it in the rehab program.
Okay, thank you.
Wonderful. Well, thank you to everyone for attending this morning, evening, afternoon, depending where you are. On behalf of Lynn Tanner and myself as the education co-chairs, we thank you guys for attending. She did post in the chat, our next education session will be in January on safety of rehabilitation. So look for details of that to be shared within the WhatsApp group and also through PSYOP networks. We are always looking for more topics and want to really address those questions of the group. So please feel free also to send those to us, and we will work to integrate those into our education program for next year. So without further ado, thank you all. Thank you, Peter, very much for a fantastic presentation.
Thank you all for listening to me. Okay. Okay.
Thank you, Peter.
Bye-bye.
It was wonderful.
Thank you. I was pleased that I would